Neurology. So like we always do, we're going to look at certain pertinent areas on neurology and what we need to know for our NCLEX exam. We are going to talk about stroke. That will be our first thing to talk about. We all know we have two kinds of stroke or two types of stroke. The first one being the hemorrhagic stroke, and the second one is the ischemic stroke. We are very much aware of them. Hemorrhagic stroke is where you have a cerebral blood vessel, okay, rupturing and bleeding into your brain, okay, depending on where the rupture has occurred. Talking about ischemic stroke, it occurs when you have, let's say a blockage, okay, a blockage, or it occurs when circulation to parts of the brain is interrupted by occlusion of cerebral blood vessels, by thrombosis or embolus. So we have this picture here to guide us. Looking at this, you see we have hemorrhagic stroke here. So in this case, you see, we've given out or displayed a vessel here, okay, a cerebral vessel, a minute one. It has been enlarged for you to know what is really happening here. So this is actually a vessel which is supplying blood to a distal part, okay. So it got to this part and there's a break, okay, or there's a rupture within the vessel, which causes blood to leak out. And in the brain, you know, when blood leak out from the vessel, it pours on the brain, okay, or it pours into the cranium. And remember, we have a normal intracranial pressure, okay, we have a normal one that keeps the brain working perfectly. So when you have blood pouring into the cranium, you know, the cranium houses the brain. When you have blood pouring into the cranium, it's like having a foreign substance adding up to the volume, okay, adding up to the volume of the cranium. And that in time creates a pressure within the cranium. It increases your intracranial pressure. That's why when you have hematoma and the rest, most of the times through craniotomy, neurosurgeons will want to drain to help ease the tension in the cranium, okay? So there's an example or a demonstration of how hemorrhagic stroke happens. Then with the ischemic stroke, here we have a presentation too. Over here, you have an embolus or a thrombus, a blood clot forming within the cerebral vessel, which is impeding normal blood flow from this direction to cross this side to reach the distal parts to be able to supply brain tissues, okay? And when brain tissues or when tissues are not exposed to oxygen, or when tissues do not receive oxygen and nutrients, you know, they die. So that is how it has been represented here too. You see the discoloration here. So it means this place or this part of the brain is not receiving oxygen and nutrients from the blood. And, you know, stroke always depends. The parts of your body which is being affected depends on where the brain has been affected or where the stroke is occurring. Okay, so let us take note. Both types of stroke result in tissue death. Of course, with a hemorrhagic stroke, if this part has been severed, and of course the distal part is not receiving any blood, it means those tissues and those brain tissues and the distal parts will not also get oxygen and they will die with time. So both types result in brain tissue death without prompt treatment. So when this happens, before, this is more practical. When someone is just about having stroke or someone is in the earlier phase of stroke, you just see, because most of the times you see the manifestations, the signs and symptoms, the parts which are being involved. So that alone can give us a clue that there is something wrong with the brain. And for that matter, an emergency CT scan or MRI will be requested. Okay, and that will help us know the location and the type of stroke that is happening. Because every type of stroke has its own specific treatments that follows it, okay, or that goes with it. You can't treat ischemic stroke as you are treating hemorrhagic stroke and vice versa. If you treat stroke blindly, if you treat stroke blindly, like let's say someone comes with symptoms of stroke and because you think because of the signs and symptoms the person is showing, you think it could be ischemic stroke and you end up getting getting the person something or giving the person something that is contraindicated to ischemic stroke, you end up worsening the situation. We look at that very soon. Okay, so the first thing when a stroke is suspected, the first thing is to do CT scan or MRI. Very important. Okay, there is something here we must know. Always when the question is given to you, look out for the history. We have CT scans that people do with contrast. Okay, a contrast dye. Okay, CON, my pen is not permitting me to write, but CONTRAST, contrast dye. Please, if per the history accompanying the presentation or the person, if the person has a kidney injury, please do not use contrast when taking the CT scan. So you will have to prompt the radiologist or the doctor who requested for it. Okay, that patient has acute kidney injury. This is one pure contraindication because the kidneys will not be able to remove this contrast. Most of them looks like a plain water. They are colorless. Those of us who have seen some before. So patients who can drink or who are conscious enough with their gag reflexes intact, we allow them to drink. Okay. Then we leave to them before the scan is taken. And if the person too is, let's say, having allergy or has allergy to iodine, do we have to also question the use of contrast in CT scan? Yes or no?
Yes.
Yes.
Okay.
Yeah.
So we have that also right away. So let us take note. Okay.
Hello, I have a question.
All right.
Please, let's say that the fellow have never taken iodine, so the fellow doesn't know whether she's allergic or not. So, what is there a test you have to do to see whether the fellow is allergic or not?
If the
He has never
person
undergone
is
some kind of
under,
test or taking something like some contrast like the iodine. Is there any
I
test
don't
you have
I
to?
don't think so. If the person is an adult and the person has not maybe indicated clearly to you, I think, and the person has no clear contraindication, you treat the person like every other person or every other patient. Okay.
Thank you.
Until, yes, until maybe you have doubt or you have reason enough to, to stop. All right. Any other question? So determining exactly when symptoms began is essential for diagnosis and planning treatment. So let us look at this part very well, especially in cases of ischemic stroke. You can never use thrombolytics in hemorrhagic stroke. In hemorrhagic stroke, remember the, how do you call it? In hemorrhagic stroke, the vessels have been severed and the person is bleeding right out of the ruptured vessels into the brain. So you wouldn't want to complicate issues by giving thrombolytics to further worsen bleeding, because you know that whenever you give thrombolytics, the person will tend to bleed. It makes the blood very, very thinner. That is why when someone is on thrombolytic therapy, we monitor for signs of bleeding under the skin, ecchymosis, melena, hematuria, all of those signs of bleed. Okay, so you wouldn't want to give thrombolytic therapy or even any blood thinner to someone with hemorrhagic stroke. That is why you will have to first confirm the type of stroke the person has. So if ischemic, so here comes thrombolytic therapy. We have group of drugs called the TPAs, okay, tissue plasminogen activator or tissue type plasminogen activator. So example is the altiplase that we have here, okay. We have other ones like kinectiplase, um, other types too, like streptokinase and the rest. They are all there. Okay, so take note of them. If you don't see altiplase, you see kinectiplase, streptokinase, and the rest. They are all thrombolytic drugs that are used to dissolve blood clots and restore perfusion to the brain. Okay, in people with ischemic stroke, like we said before. So what does this point tells you? There is something mentioned here. You see, we are saying unless contraindicated. Example, when someone has active bleeding. So it means when someone has a condition that is causing an active bleed, you don't give any thrombolytic therapy. Regardless of whether from the brain or from anywhere, you don't give thrombolytic therapy. And once one has uncontrolled hypertension, like hypertensive emergencies, like systolic blood pressure is above 180, diastolic ones above 120, you see, that's highly uncontrolled blood pressures. You wouldn't want to give thrombolytic therapy. It's a right contraindication. No matter the condition, we are talking about the brain here, but no matter the condition, we don't use thrombolytic therapy in only ischemic stroke cases. Okay, sometimes in cases like pulmonary embolism and some DVTs and the rest, we can choose to use thrombolytic therapies, but this is what we are saying concerning their contraindications. So those of us who are meeting this first, we can check it out. You see, aneurysm too is also part. And for those of us who have met it before, but maybe by one or two reasons we've forgotten, we should look at it very well. All right. Then there's another concern, still with respect to thrombolytic therapy. We are saying that it must be administered within 4.5 hours from the onset of the symptoms. So they can give you a scenario which goes like a patient was brought to the ER, which is the emergency room, okay. 3 hours after a relative or a nearby person saw the patient, showing signs of facial and left side paralysis. When this thing is mentioned in a question, the 3 hours there and the connection that is being linked to when it was seen and at the time that the patient was brought to the hospital is trying to tell you something. So if you have this in mind, like 4.5 hours, that is the window period you have if you want to treat ischemic stroke. And please, you should know that the earlier the better. If you're able to treat it within the first 30 minutes to 1 hour, your outcome is suspected, or at least expected to be better than being treated about 3 hours later. Okay. So the earlier the better. That is what we are saying here. But after the first 4.5 hours, it is not advised. Okay. It is not advised because it can cause lots of other complications. So it is better, and the thrombolytic therapy is likely to work within this window period we have stated here, 4.5 hours. So with respect to the example I was trying to give, when they give you an instance that the patient was brought to the hospital maybe 3 hours after he or she was found, then you know that 3 hours is already gone. If they tell you 6 hours, you should know that 6 hours is already gone. And for that matter, thrombolytic therapy can't be used. Okay. All right. We're also saying a baseline neurologic assessment is essential for tracking ongoing neurologic symptoms that indicate improvement or complications, which guide later treatment. So I think this one too is very clear enough. If you have any question on the slide, can let us know. Any question?
Please, I have a question.
Okay.
Let's say the people who are the time the people told, let's say they will tell you that it was 3 hours ago. Meanwhile, what the time they are telling you is not the actual time, and you give the drug. What will be the side effects?
So the thrombolytic therapy is likely not to work.
Okay.
Okay, yes, it won't work.
Okay.
It won't work as you think it should. And I'm sure there could be some other things that can even complicate. Yeah, so that is why you have to take your history very well. You can't do anything about being lied to. All that you can hope for is what you are being told is true. And that will be your fact on your side for you to work.
Okay.
Yes. Mhm.
Thank you.
You're welcome. Over here too, we are saying consultation with a speech pathologist and providing the family with information about community resources are important later. Okay, but not during the initial phase of acute stroke management. So what you are saying is that, you know that when it comes to stroke, after dealing with the treatment, you will have to bring in the pathologist to help. I mean, speech therapist, let me say speech therapist to help. Then you will need physiotherapist to, okay, to also help exercise or make good use of the patient's limbs and other things. Okay. Strokes cause different neurologic deficits depending on the location of the affected area within the brain and the extent of injury. We've said this already. We know the type, I mean, the various parts of the brain. We have the cerebellum, we have the cerebrum, the brainstem, and the rest. When we talk about the cerebellum, okay, the cerebellum part of the brain helps to maintain or helps us to maintain balance, okay, and equilibrium. So if you can run and not fall, if you can walk precisely through a particular path without falling off, then it's because your cerebellum is very intact. So people with stroke like this can have cerebellar deficits and can affect their balance and equilibrium. And when that happens, we have to institute our fall precautions. Okay, we know our fall precautions. We lower the bed. I don't know whether they are on this slide. We'll talk about them.
Hello, Brother Ima.
Yes, sister.
I know I stand to be corrected, please. I know the cerebellum. What I've kept in my mind is for coordination, or is the same thing.
Yes, for coordination and balance.
Oh,
So
okay.
you are right. Coordination,
Maybe
balance, and equilibrium. Yeah. So if you are able to, let's say if we put something in front of you and we ask you to touch it and you don't miss it, it is one way of also assessing your cerebellum, how intact it is. Okay. Or we can put up a finger and ask you to touch it. If your cerebellum has deficits, I mean massive deficits, you can't touch it. You can't stand still. So anything that has to do with fine coordination, movement, you can't perform. Are you there? All right. So we have to
please. Is it the Romberg sign that they can use, or
I think the Bloomberg sign is only with standing, right? Am I lying?
yes, please. You are not lying. It's true.
Uh-huh. Bloomberg. Are you sure it's Bloomberg? Is it? Did you say room? Is it Bloomberg or? I think Bloomberg is
Rombeck.
different.
I said
Rombeck.
Romberg.
Uh-huh.
Rombeck.
Okay.
Rombeck.
Okay.
Rombeck
Okay.
is for abdominal.
Okay. Good. Good. And I think that one is withstanding, right? Okay. So if I mean the sign is positive, it means you are able to stand erect in
Yes.
the correct posture for I think for 1 minute. Yes, for 1 minute. All right. With your eyes closed, of course. You should add that. All right. Thank you for bringing that up. Then,
Prima, please come again. Oh.
so let me write it here so that we see. I think it is ROMB. It is like this, right? Rumbeg. I think it's like this, the spelling.
Yes. Yes.
So if we want to test you, you will have, I think this is a name for, I mean, the person who discovered it. Sorry, the person who discovered it. So you will have to stand straight and like in a normal posture and close your eyes for about 1 minute. Okay. But do you think this one is for cerebellar? I think this one is different. So I don't think it's for cerebellar. It's part of this assessment, but I
This
don't
one
think
is
it's
for
for cerebellar
perception.
function. Come again.
Like I think this one is for perception, like awareness of expectations of environment.
I can't hear you
I
well.
think I would say is that like this one is for perception. That's like
I can't hear the last
awareness
part.
of
Meniere's disease,
like
eh?
I was saying no perception like
Ah,
PROISE. I think
proprioception. Okay, yes, proprioception.
yeah.
Yes, proprioception. Good. Okay, so um yeah, so I think it has some kind of balance too in it, and yes, it has some balance in it, but not only that. Okay, I think it has this vestibular and the sensory aspect of things in it. So yes, in one way or the other, I think it's also part. But in all, the cerebellum controls uh, your balance, equilibrium, and um, maintains posture. Okay, all right. Then talking about the next point here. So thank you all for your contributions, for bringing all of them. Now, looking at the last point here, depending on which part of the brain which has been affected, some cranial nerves can be involved. So by this, I'm advising all of us here to take note of our cranial nerves. It's very important. Okay. They can ask you, a patient had a brain injury and the person cannot swallow properly. Which cranial nerves could be maybe could be damaged? Okay, something like that. So if you don't know the cranial nerve, that helps to swallow, or that controls the swallowing reflexes and the rest, you'll find yourself wanting. Okay, so let us learn them. They are 12. And when you learn them, it's better it's better you learn whether they are sensory or motor, or they contain both. We have different ways of memorizing them. When you go to YouTube, you'll find some of them. Then you can stick to which one that will be good to you. Okay. And some have this kind of song they sing like oh, 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 to touch and feel a girl's feel such happiness. That is one. Okay. Then with regards to the sensory or motor parts or both, some to have something they call, some say Mary Mary, but my something. Okay. So it will guide you so that you will know. So when glossopharyngeal nerve, which is cranial nerve 9, is mentioned, you know whether it's a sensory or motor, or it contains both. All right. Okay. So that's our first assignment for today. Let us learn our cranial nerves. Okay. All right. Now we have a condition we call, okay, let us get on with what we have here when we get there. We are saying blindness in the same half of each visual field. So this is the word we are talking about. Homonymous hemianopsia. Homonymous hemianopsia. This word is very important. You can add it to your flashcards, okay? It's a topic or it's a subtopic you can be asked about, especially with the nursing management. When someone has homonymous hemianopsia, how you manage them. So we are saying when you have blindness in the same half of each visual field. So it's like for both eyes, you can't see things which are closer to, if it's affecting your right side, when things are around your right hand side, you can't see it well. You can only see things placed or things found around your left hand side. If it is the left hand side too, you can't see things which are placed around your left hand side, but you can only see right. So that is what we call homonymous hemianopsia. Okay. And it's suspected when clients ignore objects on one side. So when they give you a preamble or a history, they tell you patients, does not like to pick objects which are close to maybe one side of the body. Just that alone, suspect this condition, homonymous hemianopsia. Okay. So when patients do their things like that, in that way, suspect this condition. And we are saying initially, you, the nurse, okay, should assist the patient to help improve upon or to help manage this condition. And how do you do it? So you advise the patient to learn how to turn the head to scan the environment. Okay. It is not the patient's fault the condition is there. So you, the nurse, what you can do to help is to assist and advise the client to turn the head to scan the environment. It's very important. Okay, then as part of their management, you have to put objects at their, at the side where they can see. Okay, if you want to give them something, remember I said it's not their fault. So you place objects within their visual fields where they can see. Okay, and all of that. All right. A stroke affecting cranial nerve. This is 7, right? That the facial nerve can cause asymmetrical smile or inability to raise one eyebrow. So when they give you a condition and they mention some of these things, how would you know that this type of cranial nerve is, affected? So that is why I'm encouraging all of us to go and learn about the cranial nerves. All right. Which cranial nerves control blinking of the eye? They tell a patient comes to the ward and the patient cannot blink. As part of the assessment, the nurse found out that patient cannot blink.
Okay.
A patient, come again.
I was thinking maybe, is it trochlea?
Are you sure it is trochlea? It's a Priscilla. Your hand is up.
Yes, oculomotor,
Are you sure it is
trochlea, and then
oculomotor?
it's
Blinking.
oculomotor
Blinking.
blinking
Are you sure?
and abducens. I mean, all the three.
Are you sure? Or you are mentioning them all together? I'm not saying the patient
Yes.
can look at the left or right side
Yeah, those
or
ones
up
are
and
like
down.
responsible
Yes.
for the
Eyebrow.
motors of the eye. Yes,
Eyebrow. Okay.
Yeah.
Okay. Okay. You. If that is so. But I know that trigeminal nerve and the facial nerve too, they play important role in blinking. Okay. Some help to turn the eye to the right side, to the left, or inward. Okay. And all of that. So let us learn them very, very, very well. You can find out and you see for yourself. Okay. All right. Then there is an interesting part to talk about. We are saying that these clients can also get something we call receptive aphasia. Okay. So I'll make it simple for you. Let me see what we have here. So, okay, let us take it from here. Then after we look at the diagram. Okay. So we are saying that the clients experiencing receptive aphasia, that is impaired comprehension of speech and writing, typically have injury to the Wernicke's area of the brain. Okay, and the location is the left temporal lobe. So we have another one called the Broca's aphasia. Okay, we have Wernicke's aphasia and Broca's aphasia. Let me use this opportunity to talk about the two so that we can get to know them. This is the brain and the various lobes that we have. The frontal lobe here. We have the parietal lobe, okay, the occipital lobe, the temporal lobe here. Frontal lobe contains, it's responsible for major brain activities like thinking, reasoning, and the rest, okay. Parietal lobe too has its own function, okay, touching and feelings and the rest, okay. The temporal lobe, look at how it is. Look at how it is and the location. How can it be linked to the part of the body? Which external part of the body is in
Ear.
close proximity? Good. It's ear. So at least you should know that the temporal lobe helps you. It plays a function in hearing and also memory. Okay. Something like that. And the occipital lobe, we all know that even when we were kids, we were like, adults used to tell us that whenever you don't take good care of your occiput and someone knocks you over there, you are likely to go blind. You remember, right? So your occipital lobe also plays a function in your eye or let's say in your vision. So your optic nerve is connected to the occipital lobe, which helps to interpret whatever you see, vision. Okay. Now, we are going to talk about Broca's area and Wernicke's area, or the aphasias. All right. So that's where you have the discolorations. When we talk about Wernicke's aphasia, so let me write the word here. Please, the Wernicke or Wernicke, I don't know how you pronounce it, but is the word. Then you add aphasia. Okay, so what happens with this one is that, you see, whatever you tell them, they have difficulty. They have difficulty. I said they have difficulty. They have difficulty understanding it. Okay, whatever you tell them. So they have issues with understanding language. All right. But when it comes to fluency, they are very, very fluent. And do you know the nature of their fluency? It's like word salad. Whatever thing they say does not make sense, but they are very fluent. I'm repeating it again. With Wernicke's aphasia, so when they try, in questions, when they try to give an example, to cite an example to you that someone comprehends whatever thing that is being said. Sorry, whatever someone cannot comprehend. Okay, someone cannot comprehend whatever that is being. Let's say a nurse is caring for a patient, and the patient seems not to understand anything the nurse tells him or her. Okay, but says maybe something fluently or something. So she tell you that, or she give you an idea that this person is likely to have this Winnicke's aphasia. They can't understand anything you tell them, but they speak a lot. They are fluent in whatever they say. And mostly, there is no connection in whatever they say. It's likely to be word salad. So that is why another name for Winnicke's aphasia is called receptive. When you see the word receptive aphasia. So this is how I make it easier. Receptive, they can't receive information easy because they can't understand. Okay, so receptive aphasia is the same as the Winnicke's aphasia, and it affects the Broca's area. The Broca's area is part of the temporal lobe, the left temporal lobe. Okay, so that is what is happening. The Broca's area is in the frontal lobe. Okay, the left side. And it is the opposite of the receptive one. Okay, so most of the times another name for the Broca's aphasia is expressive aphasia. Okay, expressive. I'll also let me explain it first before I link it up to the expressive. So this one too, remember with the Winnicke, we said they can't understand, they can't receive, that's why they are receptive. Okay, but they talk a lot, and I mean they are fluent, and whatever thing they say, it's likely to be word salad, not well coordinated. With the Broca's aphasia, they understand whatever thing that you tell them. Okay, they can receive, but they cannot express themselves. Okay, they can never express themselves, so they are not fluent. Okay, so that's why we call this one expressive. They cannot express themselves. That's why we call this one expressive aphasia. Okay, so Broca's area is affected in expressive aphasia. They can't express themselves. They have language deficits, okay, but their understanding or their comprehension is more intact. That is with Broca's or expressive aphasia. Please, do we understand? I hope we will never forget.
Please,
Or is it confusing?
Please come again.
Han is here.
Okay.
Can I link, maybe in order to remember, can we link the expressive ones to that of the stammerer? Somebody who stammers a lot. You see the fellow have something to say, he's able to say it. So these people, I read somewhere, they say they say short words, they are not able to say
Yes.
talk a lot.
Yes.
So
And they use a lot of efforts.
Yes.
They stop at a point in time.
Yes. So for you not to forget, the best is to say the expressive ones, those that are, you said they are expressive people. Those people, you can say they are the stamina people. They know what they want to say, but they cannot talk for long. So they only say one or two words, which makes sense. But with the expressive ones, they, as you said, word salad. They talk a lot without making sense. You cannot make meaning out of their language. So I think
Okay.
that's what I have to.
Okay. That is also fine. That is also fine. At least it will help you to differentiate between them. Yes. So yes. So I think we take it like that. Yes. Please, do you all understand what she said?
Saima, please. I didn't
Mhm.
get what you said. No,
No,
please.
please.
Please repeat yourself. Why?
I'm saying that I read somewhere and they said those that are having the expressive one, they are those who they only say short sentences. They are not able to talk much. They only say few, but there's a meaning in it. Whilst those that are the receptive people, they make a lot of noise. They can talk for a long time, and that one you cannot make sense out of it. And I'm saying that according to me, how I now got to understand is that I took it like those who are the expressive one, they are like the stammerers. You take it like they are the stammerers. They say the word short, but there's meaning in it. And those who talk plenty, like a talkative, you end up saying a whole lot of words without making sense. So I don't know whether you're getting me. Do you
Please,
understand? Hello?
is it better
Hello?
now? This is what we're
I'm
asking.
saying that the receptive people take it like a talkative, somebody who like talking, they will say a whole lot and even end up forgetting what they said. Whilst those that are the expressive people, that they are not able to talk much, they only say few words and they will pause. So I'm saying that it's few words and they will pause. If you link that one to stammerness, those who stammer a lot, you see that they have something to say, they are making sense, but they are not able to talk for long. They talk to some point, stop, and they have to continue again at some point in time. So I link it with a talkative and that of a stamina. That's how I've differentiated the two.
Okay.
Expressive is that of the stamina, and the one
Yeah.
that is the talkative is the receptive person. That
Good.
is how I linked it. Thank you.
Yeah, welcome. I think that is also one way to help memorize it.
Okay, thank you
Hello,
very
Grandma.
much.
Okay, I've dropped
Hello.
something on the page too, so we can also look at it. Yes, sister, you can.
Grandma, please. So how is it
I want to find
related
out.
to
Please, someone is talking. Okay, so if you want to talk, kindly raise up your hand so that we don't end up getting plenty people talking at the same time. Okay, Mommy, your hand is up.
okay, and please, so we have understood. No, I have understand what
Mhm,
you are saying. So how
mhm.
is it related to when it comes to the boards exams? Like how are they going to frame the question? I don't get
Okay,
it. Yeah.
so they are going to give you a case scenario. This one, I don't know whether Let's Achieve has a similar case study question related to this. Has someone come across it before? A Let's Achieve user, or maybe a Nikhil Bank. Remember Let's Achieve? We have case study questions on it. They will describe what is really happening. Then you will have to figure it out. If you don't know what is happening, you can't answer follow-up questions. Okay, so that is how sometimes we should learn. Okay, let me give you an outside example. When, let's say, you get a case study question and the case begins, let's say, the question begins to describe someone who was complaining of severe abdominal pains, and you later found out that there was ecchymosis around the navel and around the flank. That alone, what should you suspect?
Pancreatitis.
So you see the thing.
Okay.
Okay. When someone comes to the hospital and you found out that the person has periorbital bleed or a bleed behind the ears, what should you suspect?
Basal fracture.
So that is what we are trying to do. Okay. When the
What
when
did
the
she say?
case
Oh, okay.
basal skull fracture. Okay. So when
Okay,
when
thank you.
cases are described to you,
It's a
okay,
star. Rapunzel.
when cases are being explained to you, you should be able to. So that is what makes one a very good NCLEX student. Okay, and when you see them in real life cases too, you're able to, I mean, give your input. All right. When someone, I mean, you can relate a lot. Okay. When they try to to link certain things to, let's say, a person who had what can we say? A person had hepatitis A, maybe a child. hepatitis A, and you tried to, or let's say RSV, the person had RSV, and the person was spiking. When we say RSV, I hope you know, respiratory syncytial virus. The person was spiking and the rest, and
Yeah,
the
bronchiolitis.
situation tells you that maybe the caregiver at home gave this person aspirin. That alone should give you an idea in mind. You know, RSV is a viral infection, especially among kids. And this caretaker has given aspirin. What should come into your mind even before continuing?
Rice syndrome.
So you see, Rice syndrome. Okay.
Yeah.
So these are what we try to point out so that your eyes will be widely opened. Okay.
Hello,
Okay.
Brahma, please come again. No,
Yes.
I didn't hear that part. Sorry. The rice
The
syndrome, please.
the Rice syndrome. So when you give aspirin in someone who has a viral infection, especially among children, okay, they tend to get Rice syndrome. REYE, then apostrophe S syndrome. You can read about, and they're all in your notes.
Yes.
Okay,
Okay.
they're all in your notes. So when you are reading, don't scan, please. Some of you don't read, you just scan, and you throw away more content. Take your time and read. Okay.
I have a message on your WhatsApp. Please check, right?
Okay. All right. Any other question?
Hello, please, can I talk, Brahma?
Yes, please. You can talk.
Okay. So the receptive, does it mean it's the same as is it the Wernicke or whatever aphasia you talk about?
Exactly. That's what we said. Okay. So receptive, they can't receive and
Okay.
understand. Okay. But they
Okay.
can express themselves. Okay. They can express themselves, but they can't receive. I mean, they can't understand. So they have issues with comprehension.
Oh, okay.
All
Thank you.
right. Then the expressive, they can't express. Okay. They can't express themselves well. They tend to have breaks. Like our sister said, maybe you can imagine a stammerer, a severe one. Say short words, they pause. Okay, but their understanding is very intact. Okay, their comprehension. Whatever thing you tell them, they can understand. I hope this won't be a thing that you
Yeah,
will forget. Mr. Santi Eford,
Yeah.
yeah, like with the expensive ones, I think they mostly do actions.
I'm struggling to hear you.
Yeah, I was saying with the bookest one, the receptive one, they mostly do actions. They will be doing actions because like the expressive is impaired.
Please, can someone hear what he's saying? I can't hear well.
Yeah, he's
No,
saying
you can't hear.
they get to do action.
You said they mostly do action, the expressive ones, they mostly do action.
Yes. Yes. Okay. Because they have difficulty. So depend on what the question. So this is the baseline of their condition. Okay, so let's say when you get it in question and they try to tell you that patient maybe after a head injury, so they can link it to maybe after a head injury or something. Okay, like after a brain condition. The patient talks like in short, maybe two words or two sentences, or maybe in one sentence and pauses. The understanding is intact. The person tries to use science and in all that, you have this one as your baseline. Person has difficulty expressing himself or herself, and it is linked to, the brain. So that is, I think, a true evidence enough for you to suspect Broca's aphasia or expressive aphasia. Is that it for that? Okay.
Yes, but yeah.
Okay. Is any other question? Okay, then I think we can carry on. So you are saying clients with stroke symptoms are immediately triaged using a special team and set of tools to determine the correct course of action with the goal of preventing further brain damage. Any emergency, in any emergency, the first priority nursing action is to maintain patent airway. Remember, we've said it in our previous lessons. You always use your ABC approach, okay? Except in cases of cardiopulmonary resuscitation. That is where we don't use ABC, we use CAB rather. So always take notes. Depending on the mechanism of action, so mechanism of injury, the symptoms may include changes in airway clearance, which is a priority. The nurse or another member of the emergency department or stroke alert team will prepare this patient for an immediate SCT scan to rule out a hemorrhagic stroke and determine the location and extent of the injury. So this person will also ensure that the client has 2 large bore IV lines for rapid infusion of fluids or medication as needed. It is vital to determine the onset of the symptoms as thrombolytic medications are used in short time frame, typically within 4.5 hours of onset. No, we've already spoken about this thing. So I think these things are not too new to us. Okay. Thrombolytic medications are used only in ischemic strokes. So SCT must be completed to confirm the type of stroke. We've said this. We've said you should use your ABC tool, okay? When someone has, so in the picture I showed, when someone has an issue with the parietal lobe, sensory input and some somatic functions will be impaired, okay? Parietal lobe has something to do with sensation. So I think we can learn some of these things, right? So that when someone gets a brain injury, and I mean, we are being asked which parts of the brain is likely to be affected, like I was explaining earlier. Okay. The frontal lobe controls higher order processing, such as executive function and the personality of oneself. So when you have injury in the frontal lobe, you are likely to have what? Behavioral changes. So what does this tell you? We have some conditions that affect people's behavior, and they are likely linked to the frontal lobe. Which conditions, examples of conditions can we talk about? We'll look at some in a few, maybe moments later, ahead of us. Who can mention some?
Dementia.
Dementia. Okay, so let's say Alzheimer's disease, right?
Alzheimer's.
Yes, Alzheimer's disease. You see, it affects your behavior and your personality and all of that. Okay, so the temporal lobe integrates visual and auditory inputs and past experiences. Okay, temporal lobe injury, clients cannot understand verbal or written languages. All right. So you remember the Winnicke's aphasia. So it means when it has an issue, they cannot understand any verbal or written language. So not only verbal, even written form, they can never understand. So additional information to take note. Okay. The occipital lobe of the brain is also responsible for vision. Okay, an injury to this will impair vision. I think we are done with what we want to say about strokes and the rest for now. Let us try some questions on all that we've talked about, okay, and see how best we can use them. So the first question here, regular oral hygiene is an essential intervention for a client who has had a stroke. Which of the following nursing measures is inappropriate when providing oral hygiene? If you want to answer, you can raise up your hand. Mm-hmm. Who wants to
Please,
try?
a hand here.
Okay, Samara, we can try.
Please, number 4A, the clients, because they are at risk of aspiration, the client is not supposed to lie flat. The client have to be put on a semi-fowless position, like raised a little from the bed, to prevent aspiration. Then 2B, keeping portable cycling equipment at the bedside. That's one thing we have to do, because during the mouth care, you have to suction when you are doing the mouth care. Then the D, with that we should use a toothbrush to brush their teeth. Then the C, the spatula. I think they've discouraged us from using those spatulas because it can cause trauma to the clients. So that is what my answer is C. That one is wrong among them. That's inappropriate
C is inappropriate.
for me.
All right. All right. For you, okay. Thank you. Anyone else? I want someone else to try. We are plenty here. Let us try.
Please let me try.
Okay, try.
I would like to try.
I'll go for.
Okay. Please, can I?
I think someone is talking. Maureen is talking. Then after I can come in.
Okay. With the way the small pillow under the head, I'll go for A because it will cause pressure to the brain. You know, under normal circumstance, we have to put them under, I think, 30 to 45 degrees. Yeah, like 30 to 45 years, you have to raise their head. So when you put on small pillow, it's going to, increase their brain pressure. And also,
Okay.
be keeping portable suction equipment at the bedside is needed. But that one, you have to be careful when suctioning in order to avoid pressure to the brain. C is needed and D2 is needed. So my answer is A. Thank you.
Okay. All right. Thank you. Mr. Jane, your hand is up.
Yes, I also go for A because I'm thinking
Hello.
that if you put the patients at the back, so B is okay, it's okay, yes.
Okay. 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 Thank you very much. Thank you very much. So I think the answer is exactly what we have said. Placing the client on the back with a small pillow. You are doing mouth care or oral hygiene. A small pillow, small pillow. Whilst providing oral hygiene, what is likely to happen?
Aspiration.
Aspiration.
Okay, so that is what makes this one. Remember, we are looking for something which is inappropriate. Okay, of course, when you're doing oral hygiene, you have to keep a suction equipment around. Then because you are doing oral hygiene, you can open the client's mouth with a padded tongue blade. Okay, a padded, see, a padded. It doesn't mean that it's a sharp blade, no. It looks like the spatula. Okay, so it's like saying a padded spatula. Then cleaning the client's mouth and teeth with a toothbrush. This one is okay. All right. So apart from the first one, that is wrong. Can all of these ones be ensured by a UAP?
UAP.
Yes or no?
Yes, she can do
Yes,
that.
Yes.
because
Yes.
they do activities of daily living.
Good. That is very good. So that's our rationale there. You can go through so that we carry on.
She just want. Hey, I just take these socks and send over there. She didn't wash them. Give me Kevin. Send to the bathroom.
Okay, so let's continue. We have another one here. A 78-year-old client is admitted to the emergency department with numbness and weakness of the feet, sorry, of the left arm and slurred speech. So look at, you see the age, look at what is happening here. This is the age, the person has numbness, weakness of the left arm and slurred speech. So with the problems the patient is presenting, we are asking which nursing interventions, sorry, which nursing intervention, we are looking for one. Which nursing intervention is a priority? We've talked about this, so I don't think we should even spend a lot of time here. Everybody should get this question correct. Hey, we are really keeping long on this one. The answer is just staring at us.
C.
Please, the answer is
C.
Yes,
The answer is C.
Yes.
Okay, for this one, outrightly, the answer is C. We shouldn't even waste time on this one. Remember that, you know, whatever thing that is happening is suggestive of what? It's suggestive of what? What is happening? CVA, okay, CVA.
suggestive of stroke.
But how can we know the type of stroke and the treatment to give?
Unless
So
you
that
test.
will lead us
We
to
do the scan.
good. That will lead us to the C. Scan. All right. I don't think we even need to even go through this because we all understand. All right. So the next one, a client arrives in the emergency department with an ischemic stroke and receives TP, that's tissue plasminogen activator administration. So which is the priority nursing assessment?
A.
Time of onset of caring stroke.
Which is the priority?
Are you sure?
This is question. Please, the plasminogen activator, is it the same as the hemolytic? What is it?
Oh, we talked about it.
You
Then
said 4.5 hours before when the stroke happens within 4.5 hours, you can administer.
So if you want to talk, you can put up your hand, okay? The person who asked about the TPE, I think on our first or second slide, we took our time and explained, we gave some examples.
Maybe I wasn't.
So they are thrombolytics, okay? They are used to break down blood clots. We said we have alteplase, connectiplase, streptokinase, and the rest, okay? Nashi, is it Nashi or Nashi? Your hand is up. Okay, Jane, Sister Jane, your hand is up.
Yes, I think we need to know the current medication. If the client is on any thrombolytic medication, we will need to review it.
Are you sure? You see, all of them can be correct. We're asking which is the priority. All of them could be correct. Tia, before Mary comes in.
Mr. Eva, I will go for A too. I'm going for A.
You are going for A. Are you sure?
Please,
I'm very sure because you said when stroke occurs within 4.5 hours, you can give, but if the duration is past, you shouldn't give.
Okay.
And they are already given.
My answer will be D. My answer will be D because if a patient is receiving a patient has received this strong anticoagulants, you can't do a surgery if the patient is having
It is not anticoagulant, it's a thrombolytic.
Sorry, if the patient has received this strong thrombolytics, the patient cannot undergo any imminent surgery, else they may die of bleeding.
Okay, so thank you. Richardson, you be the last person, then we move on.
Yes, I want to go for D because just
you
like
want to go for which one?
D, the last
D,
one option.
Okay. Okay.
Yeah, because just like the other lady was explaining that if a patient is on thrombolytic therapy, you have to hold this medication for 1 week before a surgical procedure can be done. And a patient with ischemic stroke, I think there is an impending surgery to take the clot out of the patient's brain. And so if you are giving, you should be concerned that if the patient needs to go for a surgery within a short period, then it means that the patient will be at risk for what we call bleeding. That is what I think.
Okay, so I now know why people tend to change their answers, why people don't want to stick to
I also go for the D now. I also go for D.
D for dog, eh?
The same thing now.
Okay, you've done well, eh? You've done very, very, very well. You can look at your answer.
But yes,
this one, yeah.
Huh? I was asking you, are you sure? And some changed their answers.
No. The way you said, are you?
Oh, but are you sure it's just a question, isn't it?
Hello,
So you see,
Emma, please, let's go back to the question.
Okay, so let's take it one by one. If you have any question, you can raise up your hand. Nashi. Okay. Is it Nashi or Nashi? Your hand is up. Before Sade comes.
Okay, so my question is, you said we have to first take history. So how can I first give the patient the to know the time of onset whilst I don't know the history of the patient?
You said, are you watching here? Please wait, I'll address everybody's question, okay?
Yes, I'm watching.
Are you watching here?
Yes.
Arrives at the emergency department with what?
Ischemic stroke.
Okay, so there's one part of the history.
Okay.
Okay,
Mm.
and receives what? Tissue plasminogen administration.
Okay.
So the priority assessments, you see, there's a reason for mentioning this one. So that's one trick. Okay.
Okay. Mm.
So this is one history enough. Then this is what the patient receives. So to add up to this one, and there's a clue for this drug, right? All of them are correct, but the priority is the time, because if the time is out of bounds, then it means this one will not even come in at all. But when you look out for, you see, consider the rest of the options. Should you look at them, it's like it gives room for you to still administer this one, just in case you are able to rule out. I don't know, maybe that's how I'm understanding it. Okay, but the time that, I mean, the stroke occurred is very important, especially while the patient is coming from outside the hospital directly to the emergency department. It's better to look out for the onset. I think it's in line with all that we explained. Well, Mr. Vivian, your hand is up.
Okay, so Brahima,
Sorry, listen, it's okay.
please. I think,
Sadiq, please wait.
okay,
Sadiq,
so
are you okay?
please, can I talk?
Okay, Vivian, you can talk.
Okay, so you said we have to confirm whether it's ischemic or hemorrhagic. Then
But
the
but the
time
question
and then
the question has given
yes,
you that it's
yes.
chemistry.
So I'm coming, please. I'm
Okay.
coming, please. So
Okay.
here it has been confirmed. In the question, it has been confirmed. And the medication too has been given. So where are we now? You said?
Please, receives.
So where are we now checking the time, the onset? Because we have to
Receives.
know that before we give.
The question is
Receives.
It's not past tense.
Receive.
It's
Receives,
receives,
not
please.
received, though.
So is it receiving it now or is that now? I'm not getting it. Received as if the client is receiving it. That's what
Something
I
like,
understand.
yes. So let us take it like that. Okay.
So if he's receiving it, why are we now assessing the time of onset of the stroke?
So
Because we have
I
to
am
do
of the
that
view.
before we give them medication.
Of
Okay,
course.
Barima.
Okay.
Barima.
Someone wants to come in, yeah.
I think the meaning of this particular this thing is that we are talking about immediate assessment after a thrombolytic has been administered. So we want to know as to whether it will even be effective or not. There are some assessments we need to do, and that is to take care, or that is to ask of the time, the onset of the symptoms. That is when we'll be able to assess whether the patient will actually benefit from what he's being given, because he has been given already. So if we are making assessment pertaining to what the medication the patient has received, then it makes sense that we ask of the time so that we know whether if the patient responds or not, if the patient responds well to the treatment or not, then we know that you see something like that. That's what I'm understanding.
That is also one way. Yes, that is also one way. Okay, that is also yes. So let me even borrow what you just explained. Please let us listen to this one. And the patient receives, it means the patient has received it, right? Before we give any plasminogen activator, a tissue plasminogen activator, like multiplex and the rest, we are supposed to make assessments of all of these before, aren't we? That is one another way. I'm borrowing what you just said. We have to make assessments of all of these. Don't we have to make these assessments?
Every time.
Yes. So it means you have to make assessments of all of these. Let's say the first, I mean the B option, C option, and D option. You have to make assessments of all of them, and even the A2, fine. So the person has already received it. And before one can be cleared to even receive, unless the person has been cleared that the person does not have what any surgical procedure, it's not on any anticoagulants or medications that will make plasminogen activator work, worse. And a complete physical history has been, taken. Okay. By the time and onset of the stroke, I'm still borrowing the idea from what our sister just said. You see, someone asked the question when we were talking about this, that what happens when you administer it after 4.5 hours? Do you remember? And the answer was, it is not likely to work if the stroke has occurred for more than 4.5 hours. Okay, so I think this assessment is to tell us, because the patient receives. So it means it's either the patient is still receiving or it's almost done. I mean, all of them is in there. Looking at the English, receives. All right. So we want to rather assess whether the stroke, the ischemic stroke, the drug that we are giving, it will work or not. So I think when you think about it that way, I think that could be fine. And I think that's also what the rationale also gave. It's in line with this current explanation. Look at this explanation. It says the time of onset of a stroke to TPE administration is critical. Administering within 3 hours has a better outcome. You see, I told you that when I even mentioned this when we were talking about it, I said when you're able to administer it within first 3 hours, you are likely to have an improved outcome than 4 hours. So it's like the more you delay, then the lesser your improvement. Okay. So TPA, that's tissue plasminogen activator, is classified as serine protease. Okay, so it breaks down the peptide bonds in them, and it is thus one of the essential components of the dissolution of blood clots. So its primary function includes catalyzing the conversion of plasminogen to plasmin, the primary enzyme involved in dissolving clots. So I think the idea is even from here, the second sentence, administration within 3 hours has a better outcome. So that's why we are assessing the time. It's not that the patient, let's kindly mute up. So it is not like we are yet about to find out about what is, whether the person is contraindicated or not. Okay. So it's like the person receives it. So over here, we are assessing whether it will have a positive outcome or not. So that is how the question is. Let us understand it in that sense, not before the patient receives the drug. Okay. But if this question had been, let's say, select all that apply, and this place is about to receive, then I think all of these options could have been correct. This one, the patient receives. So we want to know the effectiveness of it. So it means that the person has been cleared of all of these assessments. So to know the effectiveness of the drug, you rely on the time of onset of the current stroke. Please, are we all clear?
Yes, please.
Or someone will say we'll take it like that.
Yes. We'll take it
Alright.
like
Oh, this
Take
one,
it like that.
this one, I
We
have
take
my.
it like
You think it's like that, eh? But the last part I said is very important. So, in all, to cut a long sentence short, the person receives it. So it means the person has already been cleared of this drug. Okay, that person can take it. So we want to look at the effectiveness of the drug, and you rely
Hello.
on this one rather. Okay.
Hello, sir.
Yes, sister.
I'm trying to raise my hand. I just don't know where to pick it from. So this question, the answer we are choosing says that the time of onset of current stroke. So it looks like this person has had stroke before and has been on the tissue plasminogen activator. So now that the person has come to the emergency unit, the first thing, like you discussed earlier, was for us to find out the time the stroke occurs so that we know if we can go in to do the CT scan and confirm this particular one to start the, what do you call it? Continue the tissue plasminogen activator. That is how me I understand it. I don't know if it's making any sense though.
But this one, the type of stroke has been mentioned. So why take a CT scan again?
So they are saying that the client arrives at the emergency department with an ischemic stroke and receives.
So how were they able to diagnose the ischemic stroke? So you can.
So this is a past one. Hey,
So,
I'm thinking
yes.
that one is a past one. Oh.
No. So
okay.
if it's a past one, they will tell you patient has a previous history. Okay, previous history. Please let us find out, or someone can find out for us. I think one contract. So you have even brought my attention to something.
Yeah.
One of the contraindications to thrombolytic.
But see, I was even about to ask. I read that.
You're about to ask it, then find out right there and tell us. Okay.
I read that. The contraindications for TPA is patients who has had a previous head injury or stroke before, and patients who is on any anticoagulant medication less than 4 weeks, and there were actually 5. I've forgotten. I'll have to go back. So I was even going to ask that, is it only the previous slide? Is it only the time of onset that we check? Because I have read something about that before.
Okay. So thank you for bringing all of that up. I think they are very important as well. So looking at, they are all time bound. You can't say that if someone has had, let's say, a head, let me give an example. Let's say, which condition can I even, let's say if someone has had an intensive surgery, let's say exploratory laparotomy.
Yes.
For about 5 years ago, you can't say that alone is a contraindication. 5 years is too long. Okay. And the person can receive thrombolytic therapy. So some of the things that I can mention right now is that when one has, the aneurysm that we talked about, when one has, are we listening? Someone's Mary, your microphone is on. So when someone has, let's say, aneurysm, okay, or arteriovenous formation, aneurysm, especially in the brain, in a major abdominal aorta, okay, like how do we call this? Abdominal aneurysm, okay, or so any form of aneurysm, especially when it has become very, very tortuous, you can't give thrombolytics. That is one. Then what else did we talk about in the first slide? So hypertension too, we talked about. Remember, especially when someone has a severe and very, especially in the emergencies like 180 systolic and above, then 120 systolic and above, you can't give. If someone has received a recent brain surgery, you can't give what? A thrombolytic therapy. Or maybe someone has, let's say, a history of intracranial hemorrhage. History of intracranial hemorrhage is very important, or any recent head trauma or head injury, you can't give. When
Yes.
when there's evidence enough that someone is actively bleeding, whether the bleeding is from hereditary cause, what I mean by hereditary cause is like, this hemophilius and how do you call it?
Disease.
Which one?
VW.
Yeah, von Willebrand's. Good.
Yeah.
Von Willebrand's disease. Yes, yes. So all those conditions you can't give thrombolytics, right? With a major surgery, I think it is within 3 weeks to 1 month or so. Yes, so within 3 weeks to 1 month. After 1 month, I think if only the need be, we can give. Okay. Yes, we can give. And like our sister said, when someone is on thrombolytic therapy, you can't give, all right, because the blood is already thinned. So when you give, you complicate issues and the patient will bleed a lot. So these are some of the things, or let's say the contraindications to thrombolytic therapy. Okay, so like our sister said, when you've had a brain injury, a previous brain injury before, that alone contraindicates. Okay.
Raima,
Yes.
when somebody is on anticoagulants or when somebody is on thrombolytic therapy, because I know thrombolytic therapy is given is given once as the problem occurs, as the stroke occurs, and that is it. And then subsequent ones you are placed on anticoagulants and things. Yeah.
Yes.
So it's like a life-saving procedure that is done. Once the stroke occurs, they bring the patient in. The stroke team is called. CT is done, and then the therapy starts. And
Okay.
so the maintenance ones will be with anticoagulants and
with
not
anticoagulants, yes.
and
But
not
let's say if someone has been on anticoagulants for a very long time, you have INR and APTT high, too high above, it will be difficult to consider thrombolytic therapy. The person will get a complication rather than being helped. So you treat with thrombolytic, then after you continue with what? With anticoagulants. But if the person has been on anticoagulants for long, let's say you have INR of around 3.5, you go and give thrombolytics again. That's game over for the person. Okay. Someone was calling out my name. Any other question? Oh, we are all clear now. Are we clear? All right.
About pregnant women, can you give thrombolytics
Yeah, so
to
pregnant women too is another case.
No.
Pregnant women, yes, you can't give
thrombolysis in pregnancy.
But you know something? In real case, let's say if mother has a stroke, like a newly confirmed ischemic stroke or pulmonary embolism, we will have to choose one between the mother or the baby. So in these are in die cases, but in normal cases you don't give. But in die cases, I mean, most of us, if you are, I don't know if someone has witnessed some before. In real cases, okay, if you have someone, especially with PE, when you have a massive pulmonary embolism confirmed by a CTPA, okay, like CT of the, like CT pulmonary angiography. So that's the form of CTPA. If CTPA confirms a major clot in the pulmonary vessels, okay, confirms a major clot in the pulmonary vessels, please, we will have to give to dissolve that clot in the mother's pulmonary vessels. And for that matter, we are likely to lose the baby, but we save the mother. Other than that, they all die together. So those are special cases, but in normal cases, you don't give to pregnant women. Please, are we all clear? Okay. So I think we can continue if there are no more questions. If you still have further questions, you can raise up your hand though.
Hello.
Yes.
I was saying that what you said, that's true, because in real situations, they always care for the mother more than the baby, because they say with a mother, a new baby will come, but with a baby, a new mother wouldn't come. So let's say in a situation where a eclampsia is there, then the lungs haven't matured yet, and they feel like the life of the mother is in danger, they will do away with the baby so that the mother will save, they can save the mother's life. So it's not even with only this drug, but in real situation, when it's in danger, you have to ignore the other protocols and save the mother.
Okay. Thank you very much. Right. So we have our next question here, of which I believe I've voted the answer, but forget about this one. Maybe it could be a different answer, right? So during the first 24 hours after thrombolytic therapy for ischemic stroke, the primary goal is to control the client's what? The answer is blood pressure. All right. So let us take note of it. I've already voted the answer. Can we move on? So it means once, please, the blood pressure aspect, take note of it. Don't be tricked, okay? With these thrombolytics and all those things that covers it. Don't be tricked. The next one, what is the priority nursing assessment in the first 24 hours after admission of the client with thrombotic stroke? Who can try? You can raise up your hand if you want to try.
I want to just try. I'm not too sure. I will go for B. B pupil size and pupillary response is a neurologic assessment, and issues with the brain. Issues with the brain. You always have the patient, maybe you have the GCS decreasing or things. It tells you how severe patient's condition is looking. If you have hemorrhagic stroke, or maybe after the after the thrombolysis, you have bleeding into the brain or something, GCS can easily tell you what is happening in the brain. So I'll go for B, the people.
I like the way you are thinking.
Pupil size and pupillary response.
I agree with you perfectly. Or is there anyone here who wants to challenge the answer? I think we should go. We should go for it straight. Yes, that's the answer. Idris, so you want to say something?
Say no challenger is correct.
Yes, no challenger. Yeah. All right, you've done well. I like the way you started with your rationale. So I hope we are all learning something. This is also one strategy in all. We are saying the person has, we are making lesson assessment in the first 24 hours after admission with what? Thrombotic stroke. So what will be our priority assessment? At least, you know that this one is a neurologic condition. Cholesterol, fine, cholesterol will have something to do with ischemic stroke or thrombotic stroke, though. But assessments, what nursing assessments can you make which is more profound? I mean, with C and D, you take them out. Maybe because of the thrombotic stroke, you can think of cholesterol too, but this is more better and easy.
Laboratory investigations.
Come again.
I'm saying A is laboratory investigations, not
It's
necessarily.
laboratory investigation. Good. Okay. So that is it. Thank you. I think we have another one here. So the client diagnosed with atrial fibrillation has experienced a transient ischemic attack. Which medication will the nurse anticipate being ordered for the client on discharge? This is very easy. If you understand atrial fibrillation very well, without even
I'll go
looking
for
at
D.
ischemic attack, I mean the TIE, you can even
I'm going for D.
answer.
Yeah, D.
And the reason?
Atrial fibrillation. And moreover, transient. What I know about transient is it comes and it goes, like warning sign. Yeah. So I'll go
Okay,
for D.
AFib,
Okay.
Gia,
Yeah.
Gia, AFib causes a venous stasis. So please come again.
You can go ahead. Go ahead.
Okay. I said AFib. AFib causes venous stasis. So
Okay.
there's a likelihood of clot forming. So we'll give anticoagulant.
Yes. Yes. So I think that is it. Okay. The AFib requires us to give anticoagulants, and the TIA2 also confirms, okay, or it's agreeable to give anticoagulant medication. So that is true. That is true. So our answer is the oral anticoagulant medication. I think the questions are easier, right? Should have brought some hard questions. Right? So each of the following would lead the nurse to suspect that a child with meningitis has developed disseminated intravascular coagulation. And this one was this one supposed to even be here? Well, let us tackle it.
I'll go for A.
And your reason?
So the child with meningitis has developed disseminated intravascular coagulation. I know for that one, it has to do with, it's a big deal with coagulation, and then it can lead to bleeding, or I'm not too sure, but that is, I've ever read it before. So anything that will go with disseminated intravascular coagulation, I think will lead to bleeding. And so hemorrhagic skin rash, I don't know. I'm trying.
Okay. Oh, but that is true. You know,
Yeah,
this
I
question
also go
isn't
for
supposed to
A.
be here, but of
That's
course,
correct.
that is true. Okay. So remember in our previous lessons, we've said the number one cause of DIC is infection. So whenever you get a question that tells you there is an infection, and at the end of the day, the person has had issues with severe bleeding elsewhere because of the condition, then it could mean DIC has developed. Okay. So let us take notes. So I agree. That's the rationale. We carry on. A female client has a neurologic deficit involving the limbic system. Someone is asking, what is this limbic system we are talking about? Specific to this type of deficit, the nurse would document which of the following information related to the client's behavior. So with this question, if you don't know what the limbic system is, forget, you can't answer. Or it will be difficult for you to answer. Who can try? Someone will be like limbic, then your limbs, right? Your hind and forelimbs, right? All right. Who wants to try?
I'm saying emotions, limbic system connected to emotions.
So you choose which one? Option. Okay. The answer
So
is B.
B, okay.
Yes, the answer is B. We shouldn't waste time on this one. We're not long. The answer is B. Okay. So for those of us who are seeing this for the first time, the limbic system is responsible for feelings and emotions, as you see here. Okay. So let
Brother
us
Gia, can
not
you go back to the question, please?
forget.
Thank you.
You are welcome.
Yeah, thank you.
All right. So that is the rationale. Okay. This one, let's do it together because it's select others apply. So which of the following medical treatments should the nurse anticipate? Should the nurse anticipate administering to the client with increased intracranial pressure due to brain hemorrhage?
Except.
Good. So let me take the question again. Which of the following medical treatments should the nurse anticipate administering to a client with increased intracranial pressure due to brain injury, except which one? I was trying to ask you, I think I should have brought something earlier. Let me ask you this before we even solve this question. That was what I was thinking about before. When someone has increased or has the risk of developing increased intracranial pressure, what are some of the nursing management we have to ensure? Who can mention some of them?
Nursing management.
Yes, in order to ensure that patients do not get increased ICP.
So you need to, for the bed, for positioning, you need to raise the head of the bed to about 15 to 45 degrees.
Not up to 30.
30 to 45.
30 to, okay.
Environmental stimuli.
So to help reduce the pressure. And then I'm still on nursing management. You need to be doing your neurologic assessment every 15 minutes to know whether the condition is deteriorating or improving.
Pushing triad.
Please let her land, okay? Then after someone can come in.
You also need to do continuous orientation. You need to be orienting the patient to place, time, and person, since intracranial pressure may sometimes present with disorientations, or patient is likely to be disoriented. And then I'm coming. Somebody should continue.
Okay, Mr. Priscilla, your hand is up.
You wanted the BP.
Yes, I just wanted to also add that with patients who has increased intracranial pressure, when it comes to the nursing interventions, you're supposed to do it, you're not supposed to flood the patient with your nursing actions. You're supposed to do it like, I say intermittently, like one at a time, so that, because all that increases the intracranial pressure.
Good. So there's a famous statement which goes like, do not cluster nursing interventions all at once.
Yes, yeah, cluster. Thank you.
You're welcome. You're welcome. Good. Is there any other someone wants to say that we haven't said already? So let us take notes, okay? Then so whenever they give you a question like that, the person has returned from maybe a brain surgery or craniotomy or something.
Excuse me, Jim.
Okay.
There's a point that was raised about raising the head of the bed to around 15 to 45 degrees. I thought you only raise the head of the bed when the intracranial pressure has started increasing. But if it hasn't, if it's not there, you just simply put the patient to lie with the head flat. Or please, I stand to be corrected, but I think I read something like that.
Okay, so what I'm aware of is that even as a preventive measure, just keep the head end of the bed around 30 degrees. Okay, because you don't want it to even come before you intervene. Do you get it? It's like clustering of nursing interventions. We are saying you don't do that because we don't want that to happen. So it's not like it has happened and we are putting up measures to counteract it. We don't want it to come. So we are at a prevention point. Please, do you
Yes, yes,
understand?
yes. I thank you so much.
Okay. All right. Priscilla, do you want to say something again?
Yes, please. I also wanted to add that when it comes to the intracranial pressures, things like fever, pain, shivering increases it. So you have to make sure to, make sure that the patient's temperature, to prevent the patient shivering, like fever, to prevent the patient also being in pain. So you have to make sure that your pain medications are given on time when it comes to your temperature control as well, because all that can increase the intracranial pressure.
Good. Good. Okay, because when patient, when patient is in, Mr. Julie, you're coming right now, okay? When patient is in, let's say when patient is almost unconscious, or let me say GCS of 5, 4 or something, okay? Sometimes when they are in pain, you will not see it physically, but you see vital signs going up, things becoming worse. Okay, that is why they are scheduled pain medication will have to be given. Okay, from time as soon as it's time, you give measures to prevent shivering or hypothermia. You do all of that. You put everything in place. Okay, so thank you. Thank you, Mr. Priscilla. I think Mr. Julie sent us up before. Mommy, you
Yes,
can.
please. Yes, sir. So I wanted to say that these patients need to be nursed close to the nurses station
Good.
so that we can keep an eye and closely monitor the patient. And also we can give stool softness so that the patient will not exert themselves when passing stool. And then activities like coughing should be, we can advise the patient against it. Since
Okay.
those ones do can predispose. Yes, please. Thank you.
Thank you very much. So you see, Mommy, you have something to say?
Yeah, please. So is it there that you have to monitor for Cushing triad and intervene? The
Cushing,
vital signs that you are saying.
is that
No,
what you mentioned
Cushing,
something?
yeah, Cushing, you know, it have something to do with the ICP. Cheney Stokes and high BP and irregular pulse
Is that
rate.
Chinese Stokes? Chinese Stokes is a type of respiration.
Yes, that sums up to make the Cushing triad in patients with ICP. So you
Okay,
monitor
the
for
irregular
that.
breathing part. Okay.
Yeah, so you monitor for that and you intervene.
Okay,
Yeah.
good. So I think that is part of the monitoring part, right?
Yeah.
But not actually the prevention part. Yes, so you see, we don't have lots of the things we are talking about on the slides, but I think you can attest to it that we are bringing out lots of things. You are learning. Anything we are saying here, do not forget. Maybe you don't know. Those are some of the things that you might get somewhere, maybe during your final exam or somewhere. Okay, so everything is equally important. Thank you for bringing all of that up. I don't know, but I'm sure we will surely meet Cushing's triad, Cushing triad. But just to remind you, remember your widened pulse pressure, okay? Your bradycardia and your irregular respiration or abnormal breathing, however you say it. And that gives you your Cushing triad just to monitor someone with intracranial pressure.
Please, what's the name? Cushion triage.
C-U-S, let me try and see if I can write it here. C-U-S-H-I-N-G. Those of you who haven't reached neurology on your dashboard, think when you meet it, or when you get there, you meet it, okay? So when you get there, you open your eyes well so that you look at it. It's three things, that's why it's called triad. And those of you who have passed neurology and couldn't see it in your notes, shout out to you, okay? You've done very, very, very well. First came in, okay? All right, let's continue. That's just by the way. So let us open our eyes here. The things we have inside our notes. So someone will complete the whole note and try to go over again. And the person will be like, was this thing here when I was first going through? I don't know if some was okay to someone before. It means the first time we didn't look at it well. So let us pay attention to the things we read and the videos we watch. Okay. Back to our question. Which of the following medical treatments should the nurse anticipate administering to a client with increased intracranial pressure due to brain hemorrhage, except? So before you begin doing this question, you have to understand, what are we selecting? Someone should help us with that before we even begin.
If, Barima, if it's about the intracranial pressure due to intracranial hemorrhage, I would have gone for monitor, because I know monitor.
Wait, how do you understand the question first?
No, I'm not including the except. That's for the except. I don't even understand the except part.
Hey.
But I'm just looking at I'm just looking at the question itself. That's why I'm saying that.
The question itself, except is what?
I think
I don't even understand the except.
That are not
What will not be
used
given?
treatment of
That should not be given in ICP.
Good.
That shouldn't be given.
Good. Abdullah, I'm about to. Your hand is up. Good. Good. Abdullah. You can unmute and talk to us. Abdullah, I'm about to.
Hello.
Yes, we can hear you.
Yeah, please, I'll pick B, which is dexamethasone.
Okay, so we all agree that there are things that you shouldn't give, right?
Yes. I'll pick B and E.
You pick D and E.
B and E. Yeah, dexamethasone and
okay, B.
nitroglycerin,
So
except
this one and this one. So let's talk about the E first.
Okay.
Why won't you get the E? So why won't you give the E?
It's a vasodilator. It's a potent vasodilator, and when it opens the blood vessels, there will be more seeping of fluid.
Yeah, that's true.
Okay.
And dexamethasone is a corticosteroid, and it also retains fluid.
Okay, I like it. Mr. Mary.
And cause high BP, high blood pressure, what do you call it? Hyperglycemia. Yeah.
Mr. Mary.
Yes, I'm saying that I will not also give the A, because they said when there's an increase in intracranial pressure, we should stop giving drugs that will decrease the signs and symptoms of the condition, such as the.
Where is my video on?
Hello.
Mr. Mary.
I'm saying that.
Make your point clear, huh?
I'm saying that.
You are saying, okay, say it.
I'm choosing A. I'm choosing
A.
Because I read somewhere and they said that you shouldn't give things that will suppress the signs and symptoms of the condition, such as with intracranial pressure there will be a headache. So if you give the acetaminophen, meaning the client, you will not know the severity of the ICP, whether is it going high or it's going low.
So you subject the patient to forever headache, until you discharge this patient. Got it.
I'll monitor.
Okay. Okay.
I'm
Thank
going to
you.
monitor. Because if you are able to treat the cause, you'll be able to take it away.
Oh, okay.
Grandma,
Like,
hello.
yes, sister.
I think
Yeah.
answer is E. I'll go for E.
Only E.
Okay, I've chosen one for the meantime.
Okay. Who is that?
It's Carolina.
Okay, Carolina. Okay. Abdullah Abiba too. The hand is
Yes,
up.
the A for the headaches, because usually people with increased intracranial pressure have severe headaches, and it also worsens the person's condition, and we don't want to worsen the BP. So we give acetaminophen for the headache. Then mannitol is an osmotic diuretic, which will help the person reduce fluid through urination, where a catheter is also needed to be passed to monitor input and output. The phenytoin also relax the patient and sedate the patient a little bit. Then
And prevent the patient from seizures.
And E is not needed because nitroglycerin will also cause severe vasodilation, which will also increase the BP. It will reduce BP rather drastically.
You've done well. I was only surprised at one person's answer, but no further comment. Let us look at the answer.
Wow.
Is it shocking? The answer is only E. Remember, in select all that apply questions, you can get all the options to be correct, or only one option to be correct, no matter the number of options given.
So Brahima was right too.
Uh-huh. So that's why I was surprised. Uh-huh. Please, those of you who were contemplating, especially with the dexamethasone parts, I know some doctors do not give. So even in the same hospital, yes, I know about that. Okay. Even in the same hospital, Dr. A will prefer to give, Dr. B, and among specialists like neurosurgeons, Dr. B will not want to give. All right. But it always depends. Most of the times in the fresh ones, and if you want to prevent further inflammation, you have serious inflammation going on in there, dexamethasone can help. Okay. It reduces inflammation and all of that, but it shouldn't be given for long, maybe for short term. Okay. So it is not entirely bad. Are we okay? All right. This one too, I chose the answer. Okay. So we read and we just go over. A nurse is assisting with caloric testing of the oculovestibular reflex. So oculovestibular. What comes into your mind? Oculovestibular. Your eye and your what?
Vestibule.
Someone will say vestibule. Aha. So what is your vestibule? I knew you say vestibule. What's your vestibule?
Yeah.
Your ear. So eye and ear. Okay.
The ears.
Yes. So cold water is injected into the left auditory canal. The client exhibits eye conjugate movement towards the left, followed by a rapid nystagmus toward the right. The nurse understands that this indicates the client has what? Intact brainstem reflex. Yes. So this is one of the is it this one rather? Yes. So one of the brainstem reflexes, when you want to even assess whether someone has whether someone is brain dead. Okay. You just take just pour some cold water into a syringe. then you shoot it into the ear, okay, inner ear of the client. If patient's brainstem is there, intact, you see a movement, okay. Aside the papillary reflexes, corneal reflexes, gag reflexes, and the rest, I think it's also part of the reflexes. So when the patient, when this thing is done and the patient moves, it means the brainstem is there, patient is there. You can't declare patient brain dead. So that is it. So if you want to know about the caloric testing, I say it provides information about differentiating between cerebellar and brainstem lesions. So after determining patency of the ear canal, so you have to make sure the ear canal is very patent. Cold or warm water is injected into the, so you push it, it's like fast, you shoot it, okay, into the auditory canal. A normal response that indicates intact function of the cranial nerves 3, 4, and 8 is conjugate eye movement towards the side being irrigated, followed by a rapid nystagmus to the opposite side. Absent or conjugate eye movement indicates brainstem damage. So we can read more about this caloric testing. Someone should write it somewhere. You don't know where they are going to meet that. So you see what I was trying to tell you. Because of the plenty things we talked about, the questions here too are plenty. And I think they are throwing us all around. We are learning something, right? So during discovery from a cerebrovascular accident, that's CVA, a female client is given nothing by mouth to help prevent aspiration. To determine when the client is ready for a liquid diet, the nurse assesses the client's swallowing ability once each shift. This assessment evaluates what? So you see what I was trying to tell you? This is a pure likeness of an NCLEX question. So what are you going to choose in this case? If you don't even know what cranial nerve 1 is called, how can you answer this question? Who wants to try anyway? So if you are writing down something, write it as part of your assignment to check it out, okay? I think cranial nerve 9, I stand for 9, right? 9 is glossopharyngeal, glosso, your tongue, and your pharynx around your throat, okay? So I think it is part, glossopharyngeal nerve, that's nerve 9. And nerve 10 is what? Vagus nerve. Your vagus nerve innervates around your chest, your sternocleidomastoid, yeah, that muscle, up around your neck and around your jaw. So, yeah. So, the answer is likely to be D, the vagus nerve and the glossopharyngeal. So that is it. All right. Can we move on? All right. So we are done with our first part. Let's look at another thing here. It's time to talk about Alzheimer's disease. Someone will say Alzheimer's disease. So let's look at what we have here on Alzheimer's disease. The development of Alzheimer's disease is related to a combination of genetic, lifestyle, and environmental factors. Alzheimer's disease. Clients with Alzheimer's disease are usually diagnosed at age of 65 or more. Please, it doesn't mean, this one, take note, it doesn't mean Alzheimer's disease affects only the aged. So take note. This is the prevalence, okay, in terms of age, 65 and older. It doesn't mean only aged. Early onset of Alzheimer's disease is a rare form of the disease that develops before age 60. So that is telling you that you can have some developing before age 60. And it's strongly related to genetics, especially those that develop below 60 years. Children of clients with early onset of Alzheimer's disease have a 50% chance of developing the disease. Take that point again. Children of clients with early onset of Alzheimer's disease have 50% chance of developing the disease. So it means if you are a parent and you had this early onset of Alzheimer's disease and you give birth, your child has 50% chance of developing the disease. That's what it's trying to tell you. For late onset of Alzheimer's disease, the strongest known risk factor is what? Advancing age. That's for those with late onset. Okay, the strongest known risk factor is advancing age. Another one, having a first degree relative. So being your parent or sibling. Talking about your mother, your father, your sister or brother. These people are the first degree relative we are talking about. Okay, with late onset. So even if they have, even if they have a late onset, you have a risk of developing Alzheimer's disease. Okay. Trauma to the brain has also been associated with the development of Alzheimer's disease in the future. So you don't have to carry it, or you don't have to be genetically exposed alone. If you've had a brain injury before, at your later stage, you can have. It doesn't mean you will have, but you can. Okay, it's a risk factor. Brain trauma may be prevented by wearing seat belts and sports helmets and taking measures to prevent fall. So research also suggests that healthy lifestyle choices like smoking cessation, avoiding excessive alcohol intake, exercising regularly, participating in mentally challenging activities. So these ones are very important. Look at the lifestyle choices. So in questions, they can give you any form of mentally challenging games, like how do we call this? The one with the queen, or like chest, the one played on the chest or some chessboard, or how do we call that game? Who can remind me? Oh,
I think it's chess.
The chess game. It's called chess, eh?
Yes, please.
Yeah. Yes. So games like the chess game and the rest. So they can mention some of the games. They will not tell you maybe mentally challenging activities. They will mention the name. So you will have to think through. Okay. And draft 2 has to deal with the brain and all of that. So they reduce the risk of developing Alzheimer's disease. So what we are saying is, like, the more you use your brain, then the more active you make it become, and the less likely you can get Alzheimer's disease. When a client with Alzheimer's disease is being cared for in the home, okay, so I think before this one, I don't know, let me try and add one or two things, okay? Remember, we said those who get this Alzheimer's disease has something, or let's say it emanates from the frontal lobe of the brain. those of you who remember when we got to that place. Okay. And when one is diagnosed of Alzheimer's disease, let's take note that they have an average of 8 years.
Yes.
Okay. And that's an average. When you are diagnosed, one has an average of 8 years. Okay. Then there is something to, I think you won't actually see it in lots of questions, but unless questions which are extremely difficult, okay, you see questions, the questions will be like when, let's say, someone with Alzheimer's disease dies, the cortex of the brain, when examined by or let's say when examined during autopsy, what is likely to be found? Okay, then there will be like these two things, beta amyloid plaques and neurofibrillary tangles, something like that. Neurofibrillary tangles and plaques. Okay, so those are the things that you're likely to find. Excuse me. Okay. So also note that Alzheimer's disease is likely to affect more of women. Okay. When it comes to sex, it's likely to affect more of women than men. So let us take notes. All right, so the next thing to talk about is okay. I think let's carry on with what we have here. If anything at all comes up again, I'll add that. Okay. So you are saying when a client with Alzheimer's disease is being cared for in the home, the caregiver should be instructed regarding safety modifications to ease the burden of caregiving and promote the client's independence and dignity. So we have levels. I think it is here. We'll talk about the levels. I mean, the stages of Alzheimer's. But one thing is, we want them to develop a sense of independence as much as possible, because you can't do, especially at the earlier stage, you can't be with someone your whole or your entire life. So most of the times you want them to develop a sense of independence, the little things they can do for themselves. We want to encourage them for them to do. Then we can provide little help that we can offer. Okay. So over here we have injury prevention modifications that can be given to them, especially if you are a caregiver caring for anyone with Alzheimer's disease. Some of them are: one, arrange furniture to allow for free movement to prevent falls. So this is also a general fall precautions, not only for Alzheimer's disease. Okay, it's generally a fall precaution. The next one, place frequently used items within easy visible reach of the client. The next one, place locks on stair wells and outside doors to decrease the client's risk of falls and becoming lost during periods of wandering. So at a point in time, you know, they wander a lot. So you have to place locks on stair walls, okay? Then outside doors. For outside doors to prevent wandering, and for stair walls to prevent risk of what falls. Otherwise, before you realize, they are down there, and it's not their fault, okay? It's their condition. You have to label the doors to the bathroom and other commonly used rooms to assist with environment interpretation and promote independent functioning. So you don't always have to hold patient's hand and walk him or her to the bathroom. Sometimes you can do some of these things to help, okay? You label doors to bathrooms and some commonly used rooms, some rooms that the patients normally use. You can label them with a common or a nice or open interpretation that the patient can recognize, so that the patient can be using those places without help. You have to provide night light in the sleeping area. That will also help to prevent falls and aid in orientation and decrease illusions. Okay, so their rooms should be well lit or lit, right? So we have strategies also for caring for clients with Alzheimer's disease. And we are saying strategies for caring for clients with Alzheimer's disease address progressive memory loss and declining ability to communicate, think clearly, and perform activities of daily living. So our main aim is to help them to be able to perform activities of daily living, ADL. And remember, this is a progressive condition. Okay, it progresses. So I don't know whether we have this here, but we have dementia. What is the less severe form of dementia? We normally compare dementia with something.
Delirium.
Delirium. So what's the difference?
Delirium is like a short
Temporal.
temporal.
Good. So with delirium, you have a temporal confusion, disorientation, difficulty concentrating, and especially it occurs among older adults because of infection or medication hospitalization.
I think something like that.
Good. But
And
with
it's
the
also
dementia,
acute.
it's also acute, yes, like our sister said.
Mm.
Very temporal and short thing. With the dementia, you have structural changes happening in the brain. Okay, that's, remember we mentioned the frontal lobe, okay, even being part. Some even include the temporal lobe. So it's some even say the temporofrontal or frontotemporal. Which one? Temporofrontal. How do we say that? But what you're trying to say here is you have the temporal lobe and the frontal lobe all being affected. That's why you have memory declination. You remember we are saying they have memory loss. Okay, so you have the frontal lobe, which affect the general behavior, and the temporal lobe too, which affects memory. So you have both of the lobes affected, right? And it is irreversible. Okay, dementia is irreversible, but delirium is reversible. As soon as you treat, most of the times you treat the cause or you remove the causative agent. So let us take note. Alzheimer's disease is in the line of dementia. So even if you don't know, at a point in time, if you don't know, if you forget a lot about Alzheimer's disease and you know or you remember something about dementia, you can easily relate. All right. Okay. So let us take notes of them. Now to continue. So we are saying our main function or aim is towards is to address progressive memory loss and declining ability to communicate. Okay, and think clearly and also to perform activities of daily living. So caregivers should also learn to manage client problematic behavior and mood swings. Okay, you should be able to manage them. Caregivers should also learn, I think this is being repeated. So some of the therapeutic guidelines that we can use are, one, you have to use a distraction and redirection. So if clients wants to, client's problem is becoming problematic. If client's behavior is becoming problematic, or client is beginning to have mood swings, you can use distraction or redirection. So an example is like going for a walk or doing a meaningful task or something, okay, to manage the patient's agitation. Then speak slowly and use simple words and yes or no questions. You don't have to let them think plenty. So if you want to offer them food, you want to, you don't give them lots of options too. Okay, just few ones. Most of times two. So let's say you want to give patients food. You come. Rice, porridge, something like that. They should choose one. The patient will say maybe rice or porridge. That's all. Okay. I want to send it to your room. Yes or no? Okay. Not anything that involves or engages patients to give you a very structured or well-explained answers. And this is also very important. Do not ask open-ended questions. This is for those who are challenged. But if it happens to be a normal patient that you are dealing with, open-ended questions are very, very good because they end up, it's part of therapeutic communications. It end up bringing out patient feelings and all of that. But with people or among people with conditions like this, Alzheimer's disease, please do not, let me underline it here for you to see. So that's the difference. Always take notes. Do not ask open-ended questions. Okay, because it can overwhelm the client and cause increased stress and frustration. You end up frustrating the clients. So that's the reason.
Hello, please, Brahma.
Yes, Sister Vivian.
Please, does it apply to psychiatric clients too?
Yeah, so yes, with condition, if only they have conditions that, yeah, so if they're agitated and all of that, yes, so it's applicable.
Okay.
Yes, it's
Should be
applicable.
close-ended.
Yes, close-ended questions.
Okay.
When they're agitated, they have thought distortion per their diagnosis and all of that. Lots of open-ended questions and lots of questions even irritate them. Okay. So you use close-ended questions to help them. All right. Then the next one, you are saying, do not try to rationalize with the clients. So you see, do not try to reason with them. It's not their fault. So having this in mind, no matter how they give you an option, if you think it is in line with rationalizing with the client, it can be in a different, it can be in like a differently framed question or sentence. But if you have this idea, if you're able to find this idea in the sentence being provided in the question, then you should take note that no matter what, you should not rationalize or try to reason with the client. Any question on this slide? Any question on this slide? Okay. Now, I think we have continuation of it. These nursing managements are very important, so let's take note of them, okay? So we have to use visual cues or clues when giving directions. Okay, we have to use visual cues or clues when giving direction. Interact with the client as an adult, no matter how childish the patient is behaving. Please always interact with the client as an adult, even if the client regresses to childlike affect and behavior. Please, you see, we've even bolded it here. Respect client's dignity and avoid calling them pet names or any names at all. Honey or honey. Honey. Honey or honey. Sweetie, darling, or some will even try to give them funny names, not even pet names like this. They are all not accepted. Address them with their originally known name. Okay. Then we have to break down complex activities into simple steps, okay, with simple instructions. Don't complicate things to them. That's what we want to say. Do not complicate things to them. Decrease the client's anxiety by limiting the number of choices. We've said this. If you want to give them choices from which they should choose from, should be only 2. Let them pick 1. Allow plenty of time for task completion. So let's say if you are feeding patients and you give patients one thing, let's say one bite or 1 spoonful. And if patient is even taking 5 minutes, please wait. Okay. If it's a task that they are performing, let's say patient is wearing clothes, you are trying to, you see, we always say that you empower patients to perform the activities of daily living. You can actually pick up the cloth and wear it for patients or put it on patients, okay? But this time you encourage patient to do it by him or herself. Then you monitor. If they are spending long, okay, they are spending long time to put it on, just have time for them. Let them finish it as you guide them, okay? Then we are saying, allow plenty, okay, so we've said this one right now. Then the client cannot process information rapidly and hurrying or rushing, so hurrying or rushing can cause agitation or anxiety. So that is what we want to say here. So with the stages, I don't know if you can see it well, but let's try. With the stages and their eating problems, the earlier stage, they even forget that meal has been consumed due to short-term memory loss. Okay, so they will eat right now, and in the next 5 minutes or 10 minutes, when you ask them, have they eaten, they'll tell you no. Mommy, you have something to say?
Yeah, Rima.
Yes, sister.
I read something about confabulation in the early stages.
I'm listening.
Yes. And
Are you adding to it that it's part of it?
yes, and I want you to add up to me. please. I read that since they begin to forget stuff, they try and make up stories
Yes.
in other, not for maybe their family members to recognize their problem or the condition that they are having or experiencing. Is that how it is? Or
Oh, yes. Yes. So, like you rightly said, so the word used to qualify that is the confabulation. Okay. So, they try to, create false stories, or sometimes even they try to create the false stories and keep them as memories, and they take it to be true and even act on it, and it's not intentional. Okay, it's part
oh,
of their.
so to them they know, like they don't know they are telling lies, or they
They
know
don't
they are
know.
telling
Yes,
lies.
they don't know. It's not intentional.
Oh,
Yes,
okay.
it's part of the condition. Okay, it's never intentional. So when let's say you give a patient food right now, let's say you give reserved rice, and in the next 10 minutes, the patient, like another nurse comes in and asks the patient, have you eaten? And the patient says, no, I've not even eaten in the last maybe 12 hours. And the last meal I had, even yesterday, was maybe soup without any any meat or fish. Meanwhile, the patient has not even consumed any soup at all or something. Or the patient can even tell you something awkward. Okay, as if the patient is receiving harsh treatment from the previous nurse. It is not their fault. And in the patient's mind, patient is seeing that as realistic. Something that has happened. So that's one thing about it. It's not that the patient is intentionally doing that. Please do you get it. So that is one way of the confabulation.
Okay,
Gia,
thank
I have a Gia, I have a question.
All right, Miss.
Okay, so if a patient confabulates, how are you supposed to handle that, especially if it is in a therapeutic communication question? Because I think there was a time I also encountered a similar question like that, and the patient was denying that they have not eaten food while they have been.
Please come again. I can't hear you well.
I'm saying,
Okay.
how do you handle a confabulatory statement from a patient, especially if it comes in a therapeutic communication question? Because
Okay.
I remember that I have encountered a question similar to what you're saying, and the patient was denying that they have not eaten food.
Yes,
And
it's not their
and
fault.
they had eaten food like 5 minutes ago. And one of there were some choices there, but the right answer was ask the patient if they want a snack, or rather, I think it was saying offer the patient a snack to eat. So now I'm
Yes.
wondering, if you are to get it in a therapeutic communication question, how would you handle that? Because I'm not sure. Are you supposed to, will presenting reality to this patient really help? Because you have said this is a progressive, irreversible condition. So
Yes.
how are you supposed to handle a confabulatory statement?
Okay, so first one, I think this one is the most popular one among all of these things, especially when it comes to the management. Please always try to validate their feelings. Okay, always try to validate their feelings. And don't argue with them. Don't try and confront them, tell them that whatever thing that they are saying is never true. You make them more agitated. Okay.
Please validate their feeling how. Please explain.
So if a patient, how can I even give an example? So let me use the food as an example. If the patient says, let's say after serving a patient's meal in the past 1 hour. No, let me use, let's say 10 minutes. And patient, let's say another nurse comes to you, or you even the same nurse. You come to the patient again, and patient tells you that he has not eaten, he or she has not eaten. Don't confront the patient, or don't tell the patient that I just served you food 5-10 minutes ago. I mean, don't do that. Patient will try and insist on what he or she is saying, and it's not his fault or her fault. So what we are saying is validate what they are saying. So like our sister Alice was trying to say, you try and see if you can get them something. So maybe you know that they fit in for true, and that they can't consume, per your management, you know that they can't consume any other heavy meal. You can ask, can I offer you some snacks or something? Okay. Then you add up, you give to the patient takes it. So that is one way to deal with that. Please, are we clear? You don't stand in like, or let's say you don't try and prove to the patient that you just served him or her a meal just 10 minutes ago, so he or she has eaten. So he or she shouldn't say that.
Yeah, I think I
Try.
saw a question like that.
You saw a
And they
question like
said,
that, eh?
yes,
Mhm.
and the answer was you should give the patient's food again, but in
Good,
this
yes.
time, very
Mhm.
small food.
Very small. So
Yeah.
like I was saying, maybe a snack, if the question says snack or something, I mean, so you validate patient's feelings, then you try and do it. But per your management, you know, patients cannot take maybe that particular same meal in that heavy form. So you can try and change it in something like into something lighter or something, and you give to the patients. So it's good that you've even seen a question like that before. Okay, so you validate feelings. It's very important. And no matter what, don't argue with patients. All right.
Okay,
Stay
my man.
calm.
Yes, I
You're welcome.
understand. But please, if the client continue to say that every 10 minutes I've not
The
eaten,
client will
how
not
do you
continue to
do
say
that?
that because you see,
They can do.
look, you see, we have lots of reflexes. Okay, the stomach, the stomach itself. When you are full, even if you are mentally challenged, the stomach will tell you that, I mean, it's full. So if the patient is continuing to take it, means the patient is not full. But you don't have to continue giving heavy meals. You can be changing in minute form, snacks, and the rest. Give the patient as he or she asks. Okay. Or you are thinking about this patient a lot. Okay, so you have to also try and reassure them to you offer comfort. It's not their fault. Remember, I keep on saying this. Offer comfort and reassurance. Then sometimes you can help them, or you can join them to talk about the past. Okay, something that maybe they are trying to remember, or if they try to talk about something that has taken place before the word or something, can try. So that's one way of also bringing their, I mean, reminding them of their memories or something. Okay, so you can join them. That is, you don't force it out, but if they feel comfortable to talk to you about maybe a certain past, can join them and discuss freely. Then you can also help them to for them to create a memory book. Okay, so that they can write some positive memory, or some memories that have positive impact, not any negative memory. Okay, so that can also help. They can keep a memory book. So that is also something that can help. Then, so I think that is all what I can say for now. When it comes to managing the confabulation, and I think it's clear enough. when we meet questions on that, we can be able to answer, can't we? So let's go through this one quickly so that we can close for the day. At times some stuff. So forgetting that a meal was consumed due to short-term memory loss. So they tend to have anorexia, weight loss, secondary to depression, and or recognition of the disease. Then when it comes to the middle stage, forgetting to eat at all, okay, not recognizing the sensations of hunger and thirst, forgetting, so you see, as it gets to the later stage, patient gets worse. It's over here, look at what's happening here. Over here, patients forget that they've eaten at all. Okay, like they forget to eat, to even eat at all. Okay, then not recognizing the sensations of hunger and thirst. So if you don't plan their meal and serve them as such, they will lose weight massively and all of that. Forgetting how to use utensils. They can't even use common spoon and fork. Okay, then consuming non-food items. They can even eat anything they like, can chew foam, paper, everything that they get. They sometimes refuse to eat. They have restlessness, inability to sit, okay, for long to consume meal. They become like children. Inability to feed one. For the later stage, everything worsens when it comes to feed. All right. So for this one, you will have to feed them completely. They have swallowing issues too. So they even have risk of aspiration. Okay. So I don't know how many questions we have here. Let's take maybe only this one so that we can go. So encourage adequate nutritional intake for a female client with Alzheimer's disease. The next you do what? How the questions are also important. It opens your eye. It opens your eyes very well.
Stay with the client.
A would.
Stay with the, what are we choosing?
A.
A, stay with the client.
Mm.
Okay. Any different answer from anyone? I think we all agree. It is true. Our questions are plenty here. Maybe we will have to go and come back again, okay, to continue. I think we should end here. We can take this question home and maybe try and solve. You can take a screenshot of it after you drop your answer with rationale. You can send it to me privately. Okay. All right. So thank you all for coming to class today. We shall pick it up from the question session on Alzheimer's disease when we come the next time.